My name's Dhruv. I'm a senior at the University of Chicago, and I'm an undergraduate research assistant with the Department of Visual Science and Ophthalmology.
I'm Rohin Sagar. I am a researcher at the University of Chicago and at Northwestern Medicine.
Essentially, our poster is about large language models and visual language models and how they can assist the clinician in the office, essentially helping them diagnose different conditions and basically make patient experience much easier and also just much nicer. So it decreases patient burdens and it also just increases efficiency as a whole.
And so we chose to pursue this project because of the direction of AI right now. We every day are increasingly seeing more and more of a push towards the implementation of AI into clinical medicine. And so how we see with the state of ophthalmology is a lot of these clinicians are overburdened with electronic health records, with data. And what we want to do is that's taking time away from the patient, from the interactions between the patient and the clinician. And so essentially what we explore is how can we integrate large language models and vision language models into that workflow. So for example, vision language models will be used to look at the image like an OCT, and it'll identify something like more subretinal fluid within the image under the eye. And the large language model can be used with electronic health record, with past patient medical history, and all the other information, the labs, medications, to produce alongside the VLM a more curated approach to treating this patient, and also at the same time can do other capabilities such as recognizing it for clinical trial exclusion criteria.
When running this with a hypothetical work study case flow, we see that essentially it's not meant to replace the doctor. It's essentially there to assist them. They are going to be there, of course, to make sure that everything's running smoothly. And there are, of course, the doubts with it. There's AI hallucinations, there's HIPAA. There's a lot of things that AI isn't really fully able to be used right now, but with these large language models and these vision language models, we see in the future that it's being much more prevalent now, and it is becoming a lot more allowed in different spaces. So we see it basically assisting most ophthalmologists in their fields, and it really does make their lives a lot easier, and it most importantly makes the patient experience many times better.
So essentially how we approach this is to see AI not as a replacement for physicians, because a lot of the current talk and the current climate of AI and the controversy is using it as a replacement. How we see it is an essential tool that can be used alongside the clinician to enhance both the clinician's experience and also the patient experience. Obviously, in our study, we explore both the limitations that already exist with hallucinations, with even health equity, with the patient biases that already exist within medicine, and trying to find a way to implement AI without preserving those biases. The implementation process as well is already a barrier to AI, because how are we going to get it access to these electronic health records? How are we going to implement a system where AI can, the large language models could also collaborate with the people who are the recruiting end of clinical trials and the patient data end? So one of the limitations that exist within implementing these models are hallucinations, right? You can feed a vision language model an OCT and it can give you an incorrect reading. You can feed large language models a question and it can pull from an erroneous source, or it can claim that it can provide information with a cited source, and that cited source can lead to it does not exist. And that is one thing that we found. And so in addressing those hallucinations, that's why it's very important to keep the clinician as the final say, the endpoint within this process. The clinician always has a final say, and these tools are very important for consolidating all the information that the clinicians are overburdened with. But again, it's really important to keep the physician at the center of everything to ensure the accuracy of the actual model.
So with clinicians using the AI with hallucinations, of course, in an ideal world, there wouldn't be any, but we're not in that ideal world. Of course, there are going to be many hallucinations. For the actual clinicians, they have to take these suggestions with almost like a grain of salt. They really cannot over rely on it. They are meant to use it as just a tool. It is not there to make the final decision. That is why they are there. They make the final decision. They're very experienced. They're there to use their own personal judgment, but the AI is just there to help kind of streamline that experience as well. Of course, they cannot become too over reliant on it. And as you use more data, as they use more trials with it, of course, this large language model and these visual language models, they'll become trained more and they'll most likely hallucinate less. But of course, with everything, it's not going to be 100% perfect. In the current day, AI in ophthalmology is used on the administrative side. It's there to help out with forms. It's not really there on like in with the patient. It's not really interacting with the patient as much. That is what we want to see in the future, but for now, it's kind of dialed back a little bit, and it works with the administrators, it works with these forms, and it helps them make the process a lot easier with all the forms that they have to fill out. But it's not really implemented yet into actual patient care and in the actual clinics itself.
And in the future, one thing that's very exciting that we are looking forward to, and one thing that you can already observe, is a lot of these companies are already starting their own AI models and are already recruiting physicians for training when it comes to a vision language model to review an image of the eye and to help aid the model alongside that to make a better accurate reading. And so once those models in 5 to 10 years, I would estimate, come out and it can be used as a tool alongside the physician, it can really help already with the workflow by identifying specific biomarkers that exist within the eye, by identifying the physiology that correspond to a specific condition. And so that'll be really helpful because, again, it'll save them a lot of time. And another thing that I'm personally looking forward to is the ability to take all of this data and all of the patient health data and to be able to see, do they qualify for a clinical trial? Because that's something I'm really excited for the patients to experience as well. Because again, one of the biggest barriers within medicine is access. And AI is a way that we can step within that barrier and to help increase the access of medicine to everyone. There are a lot of people that qualify for clinical trials that do not know they qualify for clinical trials. And that's because they are limited with the knowledge of what is this clinical trial looking for? What's the inclusion and exclusion criteria? In the future, these AI models are going to be connected to both the patient data, but also these ongoing clinical trials that it'll automatically do that legwork to not only enhance the job of the physician, the job of the clinical research coordinators, but also lead the patient to a more promising solution for the condition that they have. In conclusion, we see these large language models and these vision language models as together an essential tool that will enhance clinicians' workflow and also enhance the patient experience and will allow the clinician to spend more time with the patient in diagnosis, in treatment, and to provide a more personalized, more comprehensive plan without compromising the integrity of all the information that is concluded from it.